Dr. Peter Wilde will give us a slight overview.
Thank you very much, Matthew. Well, I can just say, first of all, that I had not intended to give any presentation today, so I have not made any preparations for talking to you. However, the basis of this, as Matthew has explained, is to try and have a look forward as to where we might go with the whole health and care service. And to be honest, it does depend on money. Money is crucial in this whole thing. And as you've heard, there are lots of things you can do with relatively little money or even no money, depending on how well people volunteer and participate and cooperate and collaborate. But if Jonathan comes later, he'll embellish a lot more data on where we are going in the future. But he used an expression which I'm not sure I like very much, but it's very graphic. He talked about a graph that he describes as the scissors of doom. And the graph shows, which I'm sure you can all imagine, one line going steeply upwards, and these are the anticipated costs of health and care over the next few decades, based on the fact that we have an increasing age of population, which, by the way, I'm very keen to say, the fact that we have an increasingly old population is not a problem, it's something for celebration. The fact that we have had medical services that have been able to extend people's lives and useful lives into much, much older age groups than ever before. But nevertheless, as you get older, there will be increasing needs for health care. You may have some chronic condition, you may have things that need attention from time to time, or you may become quite seriously disabled. But nevertheless, the increasing population on the upper age groups, together with the complexity of what they need, is an important factor that drives cost. The second thing that will probably drive cost up is we're very good at designing technology. Jonathan will tell us in a few minutes whether technology can save us money, but on the face of it, there are an awful lot of ways in which technology costs us. We can think of more complicated operations, procedures to do. We can think of, for example, very expensive designer drugs. More and more, some of the complex cancer drugs are becoming individually tailored to patients' particular condition, and therefore they're very expensive. So what happens is you have this graph, and the third factor, I'm allowed to pause every now and then because I haven't prepared this speech. The third factor is that the expectation of us all is rising. When I was a medical student and a junior doctor, there were an awful lot of situations where a patient just had to make do with it. Well, that's the way it's going to be. Hard luck. Sorry about that, if you were lucky enough to get a sorry. Nowadays, we do expect the very best. Rightly so, and we should get the very best, but everybody has been conditioned to expect the very best. Sometimes even when the expectations are excessively beyond what can actually be delivered. But, you know, we all see that when you retire, speaking as somebody who has retired not long ago, very young, of course, but you can expect to do a lot of useful things in your 60s, 70s, and 80s, whereas in years gone by, you know, retirement was sit down and shut up and be quiet and fade away. And so that has changed dramatically. So we anticipate that the costs could go up and up and up if they carry on the way they are now. On the other hand, we have the sort of other part of the graph, hence the scissors, which is another line going downwards in the opposite direction of the anticipated funding that there is available for health and care. Now, some will argue about the politics of it, but the practicality, as some of you will have heard in earlier presentations on this session, is that the current state can be argued either way, depending on how you want to present it politically. It's called, probably most easily understood, flat cash, which is the amount of money is the same. But because there tends to be this demand rising all the time, it effectively means that in order to deliver the same services, you have to create economies. And at the moment, every year, major health organisations have to save 4% in order to maintain the services as they are, never mind build them up. And so you have this complex balance between the money, at the very least, staying flat, but probably going down, and perhaps others on the panel will talk about that a bit more, the potential for demand going up. So if we don't do anything about that, we're going to have a completely major car crash in the health service in terms of how do we make it work in years to come. And there have got to be some pretty logical answers to this. One could be, well, we just get more money. Great. We just go along and ask the government to give us more money, and they say yes. I mean, there's a bit of a bidding war going on at the moment, pre-election, for that. But I think it's fair to say that the amounts of money that are being talked about aren't the amounts of money that will solve the total health problem, but they are contributions to that debate. Should we have to pay ourselves to have health care? We've got the holy cow of the NHS, which everyone loves and has done since 1948, free at the point of delivery. But of course we do know that some things you have to pay for anyway. You have to pay for prescriptions, you have to pay for dental treatment and a number of other things. So it's not completely free, but the mainstream is free. So there's a debate to be had, should we actually start asking people to pay more for different things? Then you could go to another solution. You could say, okay, we can't do this, we've got to ration, we've got to cut services. And so you then have to decide how you might cut the services. So you might, to use a medical analogy, either just amputate, which is to remove certain services altogether from certain areas, so we can't do that anymore. I won't speculate as to what that might be. Or you could just squeeze down all of the services a bit and make them tighter, which will create all the inevitable problems of rationing and then waiting times and all the problems that delivers. Or you could then just do things in a smarter or clever way. And that's another way that we could do it. If we can actually build out of the system all the things where money is spent more than it needs to be spent, and I think Ron may have something to say about that, whether we can do things more efficiently whilst maintaining quality, because don't forget, nobody, after some of the experiences that we've seen over the last few years, wants to see quality down. Quality is the holy sort of cow that we're trying to maintain. So we don't want to see quality drop, but can we maintain our quality by doing things in a cleverer and smarter way? So those are the balances, and had Jonathan been here, he would have said what I've said slightly more eloquently and also with a little bit more data to back him up. But nevertheless, I'm sure you get the gist of it. The final thing that I was going to say is there's another big issue, which is, of course, we talk about health and care. And when the NHS was invented in 1948, of course, there was health and then there was social care. And they have always run on separate tracks, and they've always been free at the point of delivery in the NHS, and in some form or another paid for services for social care. And of course that's created this really, really difficult zone that lies between them as to how you pay for one thing but not for another. And there are awful examples where you can really be sitting on a knife edge in the middle. You know, if you've got Alzheimer's disease, is it a disease? If it's a disease, you should be treated in a hospital or in a NHS facility because you've got a disease. If you're just old and not as bright and smart as you were before, you just need care. So then you pay for it. So there's a very narrow judgment, and of course the incentives are different as well. There are, if you like, hospitals and other NHS services are paid by what they do. In other words, the system is there designed for them to keep going on the basis of piecework, almost, if you say it like that. Whereas social care has got to be paid for out of a block of money which is now administered by the local authority, and therefore it has to be eked out in the best possible way. So you've got two things that I'd like to leave you with. One is the scissors of doom, the graph going in the opposite directions that we're facing. And secondly, we've got two different systems that work very differently and that we would like very much, I'm sure most people, to integrate, but that's a big challenge, and how they're going to be integrated is going to be one of the next challenges for the next few years. So that's a very short and amateur summary of what Jonathan might have said had he been here, but he might correct me later.